Also, I think that the field is moving to combinations. So, because certainly if the patient is responding to checkpoint inhibitors, the response is outstanding, and the median survivals that have been published in second and certainly in first line based on phase 2 data with survival, median survivals beyond 20 months with nivolumab. So these are very good survival rates, but the patients that achieve stable disease or, needless to say, progressive disease, certainly are primary resistant to checkpoint inhibitors. So now there is a trend in almost all the trials to combine TKIs with checkpoint inhibitors in order to boost the immunity in this percentage of population that is 60, 70, 80%. Particularly those with immune exclusion that are silent, completely silent from the immune system, to boost the immunity there. And certainly a lot of efforts, and we're seeing combinations with lenvatinib pembro, regorafenib pembro nivo. We're seeing bevacizumab atezolizumab in combination, and all these efforts are maybe probably able to rescue some of the patients that are certainly not responding to checkpoint inhibitors into responders, so switching cold tumors into hot tumors. So what's your take in this combination?
I'm eagerly watching those trials as well, and also the addition of the checkpoint inhibitor combination with the CTLA-4 plus PD-1 or PD-L1 inhibitors also to be added to that list, such as the durvalumab plus tremelimumab combination or the nivolumab plus ipilimumab combinations, which are all eagerly awaited. I guess one of the questions from the scientific side or from with respect to tumor biology is, of course it'll take clinical data to tell us which is the best strategy for which type of patient, but we also have the combinations of liver-directed therapy plus checkpoint inhibition with the idea of, will that better create immune infiltration or convert a tumor from hot to cold to hot rather?
Yeah, that's
Do you have a thought about those combinations on the horizon?
Yes. But certainly I would say that in advanced HCC, certainly the field will be dominated by the combinations for the next 5 years. And there are preliminary studies suggesting that these TKIs may be able to increase the CD8 cells infiltrate into the tumors and decrease the Tregs. These are the two main mechanisms that are out there. In terms of local regional therapies boosting the immunity, there are few studies, phase 2 small short studies, but also the release of antigens certainly may also induce, enhance the immunity there. But how I envision the field in the intermediate HCC moving is most trying to move the combo already in advance into intermediate, and then on top of chemoembolization or head-to-head even. This is how I envision the thing.
The checkpoint inhibitors monotherapy is just, response rate is just less than 20%, but recently combination immunotherapy is ongoing, trials is ongoing, such as lenvatinib plus pembrolizumab, which was presented at ASCO last year, and the response rate was 43% in 26 patients, and the response is durable. And also at the same meeting, the atezolizumab plus bevacizumab data was presented. But at that time, the response rate was very high, 65%. But in ESMO meeting, that response rate was dropped to 32%, but still relatively high, and the response is durable. So those checkpoint inhibitor plus TKI or anti-VEGF antibody is promising. Another promising agent combination is PD-1 or PD-L1 antibody plus CTLA-4 antibody like nivolumab plus ipilimumab. another PD-1, PD-L1 plus CTLA-4 combination is durvalumab plus tremelimumab. This durvalumab combination are also phase 3 trials are ongoing, and the atezolizumab, bevacizumab also phase 3 in BRAVE trial is ongoing. So those are very promising. Response rate is very high, and response are durable.
The IMbrave 150 trial was a very interesting study, or is a very interesting study, which looks at the efficacy of anti-angiogenic drug bevacizumab and an immunotherapy agent atezolizumab. So basically the combination of immunotherapy and anti-angiogenesis. And there are some preclinical data which suggest synergy. So there was a clear rationale to use these drugs in our patients. And we have seen the first clinical outcome data. At ASCO, it was a very, very strong signal with a response rate of 60%, which was really remarkably high. At ESMO, we got an update with more patients. The response rate dropped to 34%, which, however, is still higher compared to what we have seen before. So far, there are only 70–80 patients included, so we have to be careful. But the first initial signal is strong and is in line with other drugs we have, or other combinations we have seen. So TKI and immunotherapy, then lenvatinib with pembrolizumab, for example, also the first data have been reported. And similarly, we have a response rate of 37%. So I think at the moment there's a clear indication, as we have seen it in other tumor entities, that when we combine immunotherapy with TKIs or with anti-angiogenic drug, we might have more efficacy. It's not yet clear whether it's additive or synergistic efficacy, but it looks like very much that we will go to combination therapies in the future.